let us get 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at those answers. Everyone has their thing they don't like dealing with, and I know one of the things my wife does not like dealing with is feet and toes, so it gave me a little chuckle when I put this question together. Now, for those of you that haven't had much to do with toenails, I think the natural knee-jerk reaction here is to say, this is a fungal nail infection, but I want you to focus in on what is actually some of the things you'd be looking for to determine, is this a fungal nail infection? Is this perhaps something different? So what are the examination findings? Go back to first principles. Think, what am I actually going to see on these toes? Even looking at this picture, and sometimes looking at the pictures gives you that bit of a hint of what kind of things could you be examining for. And certainly that kind of crumbling, chalky, brittle nails, you can see that toenail there looks like it's very, very crumbly underneath. You can see all that keratin and dead skin cells trapped underneath the nail there, lifting it up, as well as the direct thickening. That would be something that I'd be looking at there. Now, it has been pointed out here, a lot of those are already visible in the pic. Yes and no. So, crumbling, chalky, brittle nails would be an examination finding. That nail, if you actually touch it, might be hard as a rock, or it might completely fall to dust the second you touch it. And so I think you could make that argument there that it is a new examination finding. Longitudinal streaks running from tip to base. I don't think you can clearly see that in this picture here. This is intentionally a bit of a kind of vague, semi-obscured, not very clear picture, and so I think would make it fair game, to be honest. Presence of flake wet patches on the nail, yeah, you got me there. That one's on there, and you are correct, it does say further. Elevated from the nail bed, that one, I think you might get a hint of it here, but specifying exactly that you're looking for that, I think probably would still get your mark. Malodor and offensive smell, if you have smell-o-vision, I feel sorry for you because this would not be a great time to find it out. But again, thinking about if you're in that room and that patient and that foot is in front of you, what kind of things might you notice? Scaling on the plantar skin or web spaces isn't clearly visible here, and that took me a little while to find a picture I was happy with. Intentionally not here, and so I think would be something you would specifically look for. You are correct, though, in terms of scaly erythema in the interdigital spaces. I really love that wording there, again, reflecting that consultant level knowledge. Psoriatic plaques on extensor surfaces, perfect. Unusual bold spots on scalp. Yes, if you're really going down that kind of psoriatic pathway, I think you certainly could put that down, and again reflects that kind of broader base of knowledge you're working from. Horizontal ridges in nails, yes, I think would get you marks there. Again, on this picture here, not very vague. You might actually get a little bit of a hint of it. Here we are. Bring my mouse into view. A little hint of nail changes coming up along this nail here, but you would be specifically examining for all the rest of the nails as well. And yes, as you stated there would be alopecia areata. All right, now there's of course more to this question. Where could this be going? Let's put 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at what some of those answers could be. And we have here a few things. Nail trauma, and this is traumatic onychosis, is something that I think probably gets missed more than it should. And we end up treating a lot of patients for what we say are fungal nails that actually don't have any response there. And sometimes it's frustrating, you know, you're treating, you send off clippings, they never seem to grow anything. Remember that nail trauma can present very, very similarly to fungal nail infections. Of course, that is the other likely candidate here in terms of fungal nail infection or onychomycosis. Eczematous or psoriatic nail changes can present very similarly as well. You can also have nail changes related to things like renal disease. There's lots of other conditions, of course, that kind of factor into there as well. And I think if you're putting any of those kinds of things, you're probably going to get a mark. Renal disease was just one specific example here. And there is yellow nail syndrome as well, which if you're not familiar with it, can present with yellow nails, surprise, surprise. The thing that leads against that here is that we only have 2 nails involved, whereas yellow nail disease, you would expect all nails to be involved. Now, we do have here right big toenail psoriasis, and yes, I think that probably would get you marked. If I wanted to be really nitpicky about it, I would actually say that this question points out that it actually started on the left big toenail and seemed to have jumped across to the right as well. And so you could probably say bilateral big toe psoriasis. And I think you'd probably be more guaranteed to get those marks there. But certainly if I was doing it, yeah, you got marks. Onycholysis of big toes, onychomycosis of big toes. Absolutely fantastic answers there. And again, I like that you're thinking of that kind of more trauma type activity here. So one of the things that is often frustrating for patients that have that kind of presentation is they say, oh no, I don't remember, hurting my toe or damaging it at all. It can take up to 3 months for the injury to actually present in a clinical fashion with those nail changes. And often by that time point, the patient's forgotten that they actually stubbed their toe or dropped something on there, because it actually doesn't take a whole lot of trauma to cause permanent nail matrix damage that causes that thickening of the nail. With that, the nail can lift up off the nail bed. You end up with a whole bunch of skin and debris trapped under the nail, which gives it that kind of almost fungal-like appearance. So always remember, if you're setting off samples, no fungus is growing, ask yourself, could this actually be nail trauma? And try treating down that pathway, which really is more of a conservative type pathway. But excellent answers there. Happy to see them all. And I think in an exam, you'd absolutely crush that. Okay, we have part 3 here. Let's put 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers here. And I think some of the low-hanging fruit is, of course, going to be send that patient to a podiatrist. Now, again, this is specifying time frames, so regular, who it's referring to, podiatry, and what for nail care. I think putting that down is going to get you full marks here. Some of the other things that I think are really, really important to do is try and backtrack and work out what has perhaps caused this change to occur, because you want to prevent further nail trauma to other nails as well. So one of the common things, particularly if you're looking at bilateral big toes, is are they wearing pressure-inducing footwear? And so making sure they have wide footwear is incredibly important. If this is something that isn't responding well to regular podiatry, or they're really frustrated by it, really sick of catching on things, sick of the appearance, you can actually elect for surgical nail removal. So ring block, take that nail out, and there's a chance that the nail will grow back more normal. 99.999% of the time, though, it's just going to grow back and do the same. And so you can actually use phenolization or nail matrix ablation to destroy that nail matrix, and the patient can live a happy, full life without a toenail. Probably the more extreme example here, but every now and then you'll find a patient that's just so sick of it, they just say, look, let's just be done with it. Now, we do have some excellent answers here in terms of trim nails close to the skin. Yes, this can be helpful for trying to reduce it catching on things, particularly if a patient's prone to scratching themselves or trauma from there. It doesn't tend to help as much in terms of the debris caught under the nail, but as you've already put in, avoid using soap, avoid using irritants, and I like these specified as well, avoid nail water immersion. And so you do sometimes see these kinds of toenails in people who do lots of swimming or have lots of water-based exposure, prolonged water exposure or nail immersion will soften the nail, cause it to swell. That can bring about things like cracks and fissures, and doing that repeatedly over and over can traumatize nails and lead to this kind of thickening process. So yeah, not in the matrix, not in the answer matrix here, but definitely I think anyone that knows anything about nails would be giving you marks for those responses there. Well done. All right.